Good morning and welcome to ICUS Bubble TV. I'm Linda Feinstein, and today I have the pleasure of speaking with Dr. Petros, who is here from London and Greece to speak with us today about contrast-enhanced ultrasound and how it benefits his patients. Good morning.
Good morning, and thank you, Linda, for this morning interview. That's great to be back in Chicago after, well, almost 3 years of COVID restrictions, which was really bad for us, and we love Chicago. We love this meeting, to hold it live and see good old friends, but also new friends, because I can see the Bubble Society, the ICUS Society expanding with many more young people, doctors and sonographers alike, to wanting to be more and more involved with bubbles. Bubbles is the way forward for diagnostics, not only in cardiology, Linda, that I am a cardiologist, obviously, but also in general radiology for all organ systems of the human body. So starting from myself, Linda, I am a cardiologist, clinical cardiologist, not a surgeon, not an interventionalist. I'm a proper cardiologist, as we say, in London. And I live and work in London for the last 40 years. I arrived in London from Greece in 1982, when I was doing my training in cardiology. And not soon after that, I think it was in '88, where the first contrast agents were becoming available as research tools at the time. Mark Monahan was a leading physician in London at the time, involved in contrast because of his relation with Steve, and got me interested in bubble research. And we started doing some early contrast research work with Levovist at the time. And we made the first publications in JACC at the time with Tom Marwick and many other European investigators. So that was my birth time of bubble research.
And you've certainly been involved from the earliest stages onward, and you are a pioneer in the field.
In Europe, at least, yes. I very quickly, I was a clinician, I am still a clinician cardiologist, and I realized the needs for having some enhanced imaging, not using ionizing radiation. So nice in the hands of, at the time, Linda, I remember cardiac ultrasound was fundamental imaging, not a lot of technological developments in image quality. So contrast was really a need at the time, and it was the change of imaging quality was phenomenal. Obviously, subsequently, both the vendors improved their imaging ability, quality, adopted the contrast technology, so they improved their imaging technologies to allow for the contrast agents to be imaged as well. So, and as a perfect marriage, technology and contrast technology developed to reach this level of today's, with so much improvement of both image quality itself, but also looking at perfusion, bubble circulation into the microvessels, the capillaries of the heart muscle, which is unique. If you were thinking some 20 years ago, it was almost something unimaginable to be able to see. And our friends in nuclear cardiology were saying, oh, we can look at myocardial perfusion and this and that. But with the expense of ionizing radiation, which was actually considerable, especially some 10, 15 years ago, ionizing, a very good friend of mine, Eugenio Picano from Pisa in Italy, was saying that one nuclear test for cardiology was equivalent of something like 1,000 chest X-rays. Because if you say so many gamma radiations to the people out there, say, okay, what does this mean? Well, it actually means 1,000 chest X-rays. That's not negligible.
So the contrast-enhancing agents are able to help avoid that exposure to ionizing radiation.
Well, precisely. No need for ionizing radiation, and we can get at least the same, if not the better result, both for image quality of real-time heart muscle involvement, movement, but also myocardial perfusion to look at the microcapillaries of the muscle itself. So we can separate whether a heart attack, for instance, myocardial infarction, is fully infarcted, there is no viable myocardium there, so revascularization may not be very welcoming, as opposed to the viable myocardium where there is blood flow in this area of the heart attack, the myocardial infarction, and how extensive area of viable myocardium is around this area of scar of following the myocardial infarction. So valuable information, so useful information, unimaginable some 15 years ago.
Remarkable.
And it's so easy, just with a simple injection. So all you need, in fact, in Britain, our sonographers are can be qualified in injecting drugs and contrast agents in the vein, in the forearm vein. I know here in the States is a big issue, but every year
we're working on eliminating the issue.
Arguing about that.
Yes.
Our sonographers, they sit some tests and they are getting qualified from the local hospital. So the sonographer himself can decide, oh, I cannot image this part of the heart very well, I need contrast. So he goes to the fridge, gets the contrast vial or the agent, and injects, and then light comes in front of her or him and sees the question in.
So it appears to be simple, safe, and potentially life-saving.
Well, life-saving, it's not an ICD device that can start the heart from
but you may pick up a
arrest.
disease that you might not have seen otherwise.
Of course. And there are some studies how useful this contrast injection is. But I want to emphasize how easy it is for the sonographer to take the decision himself, get in the fridge, get the vial, get the line in for image enhancement. I'm not talking about perfusion here, for image enhancement, which is, for me, the four big image necessities to use contrast from the transthoracic echocardiogram is to look at the apex. Linda, people may not think about it, but the apex, the cardiac apex, is one of the most difficult parts of the heart to image transthoracically. You think that, I position my transducer at the apex and I can see the apex. No, 55% of the times you do not actually see the apex, either because the cut is oblique, and so you don't see the tip of the heart per se, or because the apex is not imaged because of the artifacts, because of the reverberations, and because of all these technical issues that the ultrasound cannot quite see the apex. So you may think that you may miss a thrombus, you may miss a apical cardiomyopathy, you may miss some other types of cardiomyopathies, and you can miss an aneurysm after myocardial infarction. So for those four reasons, contrast-enhanced imaging for the cardiac apex is an absolute necessity for me. So even if you think, I can see the apex, actually I can challenge you, actually you do not really see the apex. So use contrast to image the cardiac apex properly and securely. So you don't miss a thrombus, you don't miss an aneurysm, you don't miss a cardiomyopathy. These are the three main points that I want to take out of this interview.
Thank you so much. We really appreciate your thoughts. If you had anything else you'd like to say to our viewers, please share your ideas, and we are so appreciative of your being with us today.
You know, Elinda, I only spoke half of my passion about contrast. The most important for me, for daily practice, is stress echocardiography. And in London, I work at Imperial College, at Hammersmith Hospital in London. So there is no way that a stress echocardiogram, and we do about 10 a day, there is no way that a stress echocardiogram can be performed without the use of contrast. We do in London and in Europe generally, mostly dobutamine stress echo. So dobutamine stress with contrast is an absolute necessity. So you see the apex properly, for the reasons I said before, but you also look at perfusion. So without even needing extra work. Yes, you need to modify a little bit your settings. You need to be a bit experienced, not a lot. You know, you do 5, you've done them all, you've seen them all. So you see perfusion at the same time as you can see and evaluate contraction of the heart during at rest and during stress better. So it's absolute necessity transthoracically, but also for stress echo, 100% use contrast. Don't do stress echo with dobutamine and no contrast. You will miss out half of the information you will be able to get.
Thank you very much. We really appreciate the opportunity to speak with you today. Thank you.
My pleasure.